Hey everyone, this is the Nips and Sips podcast. Today we're going to be talking about high ankle sprains or syndesmotic ankle sprains. But before I get into this, let me pass this off to my partner in crime, Dr. Brandon Cruz. How's it going, Brandon?
Doing well, dear. Thanks for the introduction. Appreciate you leading the way as always. Got a gorgeous Tuesday here. Looking forward to finishing up what we started with our last podcast about ankle sprains. As you said, we're going to be talking about the high ankle sprain or the syndesmotic joint ankle sprain. And it's probably going to be a little shorter of a podcast. I think we covered a lot of things, but I know we didn't get a lot of time to touch upon this one. So we kind of made it its own podcast, but it's going to be a little shorter. I'll go into drinks. I'm back with my cracking backs and dropping facts. So we'll be dropping facts today. I have my new drink, my Noble Oak, which I am liking thoroughly. So that's what I'm drinking here today. Jared, what do you got today?
This has actually been a beer I've been holding on to for a while. I've had a couple of these, but I was like, oh, it'd be nice to get this one on a podcast. It's from Honor Brewing Company, and it's a line of sight lager. They have a really cool theme. They seem to be maybe veteran owned or of that nature. Pretty decent lager. I've had a lot of IPAs and everything like that, so to get a lager, it's pretty refreshing. So there we go. Drinking out my Core 3 cup, just kind of cool. A newer brewery by us down here in South Jersey.
A lot of breweries down by you.
Yeah, there's got to be, I don't know, at least, 10 within just a couple miles. So, but yeah, this is kind of just a refreshing lager. I give it a solid 6.8.
6.8. All right, dropping down a little lower than what you've been ranking.
Yeah, and that's just my preference. I do like lagers, but I don't usually go for them unless it's something I'm going to be drinking a lot of. But yeah, it's pretty good.
Nice. I see you have the throwback Pursue P t-shirt on, repping my company, and that's the original shirt right there.
Is it the original?
Yeah. Yeah. What do you have in the back?
It's just, I think it's white.
Yeah. Yep. That was
the OG original, huh?
First shirt I got those. Those were supposed to be a heather blue. It looks a little grayish, but heather blue.
Like it.
And then the second one was the gray t-shirt. And then I went back to a navy blue by Nike for my third t-shirt. And now I'm actually wrapping up those. So I might go to the high elite ones next. So you got the first gen right there.
Yeah, I was looking through all mine. I was like organizing all my business t-shirts and I had a couple from yours, and this one came out. I was like, ooh, I got the blue one, I got the gray, I got all three. So I'm a lucky man.
You are. All right, let's get started with this episode. And enough talking here. Jared, I want you to I guess just kind of lead the way out here, because I know you're in the sports fellowship manual therapy program. You probably see more athletes than I do. So I guess just in your experience, do you see this a lot? If so, are they coming to you direct access? Are they not? If they are, what are you looking for to differentiate between a high ankle sprain versus a regular ankle sprain, or possibly even like a knee injury or a fracture? What's your differential diagnosis for this type of injury, as I guess it can be a little tricky?
Yeah, definitely not as common as your classic lateral ankle sprain or seeing people with chronic ankle instability like we talked about last time. But I have had a handful of those. I was talking before the show I've had a handful of people who had a concomitant high ankle sprain when they were just diagnosed with a lateral ankle sprain, and almost vice versa. It was like they're diagnosed with a high ankle sprain but didn't really present like it. I've had only a couple throughout my career, fortunately, because it does takes a lot more to kind of bother that syndesmotic tissue. So the rehab's a little bit longer. I can't say I've had many via direct access. If it's the case, whether it was a proper diagnosis or not, they were seeing an ortho first. Simply, I assume so it's going to be a little bit more painful, a lot more difficulty bearing weight or kind of propelling or pushing uh, off of kind of a loaded dorsiflexion position. So pretty much when in the cases where I have seen it, this is a good. I'll put up the article first for anyone who's interested. It's that actually athletic training article. And maybe that's why we don't see as many, because it's falls under the scope of athletic training. And while I'm at it, let me make sure you can share whatever you want to share.
We're getting better at it.
Yep, we're on top of it. It's simple rehabilitation of the syndesmotic high ankle sprains by Williams and Allen. So really just a good basic. If you're not familiar with this type of diagnosis, it's a really good outline of what to look for, both the examination and kind of in a basic way how to highlight the phases from acute to subacute to chronic. But if you kind of go through it and everything like that, they show the kind of like potential clinical pattern. Something that I saw initially with one of my clients, again, was more that we expect swelling and bruising post any serious type of ankle sprain. But most of the time when you have that lateral ankle sprain, it kind of just hangs out just kind of a distal and posterior to the lateral malleoli and kind of like encircling around it, versus those high ankle sprains, as you see in this picture. You can see a little more swelling, more superiorly, and more toward that syndesmosis. So that's kind of one telltale sign. The person we had wasn't to a point where they had like that bruising, but it was definitely more tender, and I think they had like slight like pitting edema in this area versus more so below. So certain things that I look for. We still apply like the auto ankle rules is a good way to determine if they need a fracture, because sometimes fractures go undiagnosed during first imaging in the ER. Really depends on where you're going in the ER. South Jersey, if you go to local hospitals, it's like you're batting 500. That's why I say if it's anything serious, go to the bigger cities, especially with like kid fractures and stuff, unfortunately. So we use that both in the knee and ankle to kind of make sure nothing was missed. We actually had a client who's getting seen by my resident, Justin, and she was in for knee pain, but she tripped over her dog recently, and she's on blood thinners, and her ankle was, purple all the way from here on up. And she walked into the clinic and said she had no issues walking or anything that day, like the day that she came in, but the day before she had some difficulty walking. And I was trying to like help Justin kind of go through that process of understanding that auto ankle rules. He was like, I think I should send her out just for because it was tender. Potentially that may be the case in that posterior lateral tip of the lateral malleoli. But does that really warrant a true referral out? If she was walking on it, those sort of things, she seemed like she had a good gait pattern. I expect things to be pretty sore when everything's kind of bruised up. So just kind of help them walk through it. But to go through it, these are the big kind of tests I'll do to kind of rule in a high ankle sprain. The big one is the external rotation test. Is probably the biggest one I'll perform, and also the squeeze test. So they go into those. I haven't done the taping. I've done taping of like the lower ankle, but I haven't done this quite yet. I just didn't feel a need to. But just going into more about this article, these are some basic guidelines of how to kind of progress these people. But again, as you see, very basic, not specific at all. But that's kind of how I kind of approach it. Again, a good article. But what about you, Brandon? I feel like I talked a little bit.
Yeah. So just so everybody could see, and I have the test pulled up here and what they look like. And so this is that test you were talking about, that first one, and I had said Kliger's test or Kliger, where you're adding that dorsiflexion and external rotation, where and that's basically the mechanism of injury. So this test kind of recreates that, and these people who have it, they're not going to let you get very far into it because it's going to hurt. So mechanism of injury, I think that's always huge too. So I just want to touch upon that, Jer.
Yeah.
Contact sports. We see it a lot in football. If you guys out there, audience watches football, Gronk had it. They rushed him to surgery. Obviously, it's a little bit different in professional sports because they're trying to get. They only have 16 games in the playoffs, so they're trying to get people back as fast as possible. And this probably takes a good, what would you say, Jared? 2 to 4 months, if not longer, to really recover from. And even then, at that 2-month mark, you're probably going back a little earlier than expected. So don't go by what the professional athletes do. They're getting paid millions of dollars to put their body on the line. Other sports would be like hockey, or anything where like your foot or ankle is kind of like in a boot. And in those contact sports, maybe baseball, depending on a slide, you might get something like that, but you probably end up fracturing it before that anyway. But those are your typical mechanisms of injury. Increased dorsiflexion with the eversion component. A fibular stress test, which is basically like mobilizing the distal fibular component there, which is going to stress that interosseous membrane. And then the last test would be that syndesmotic squeeze, which you talked about there.
Yeah.
As you can see here at the bottom, the psychometrics are lacking though within that test. It does reproduce pain there. So that's kind of what we're looking at with that. And then, I haven't had too much, again, direct access. It's usually they've been in a boot. They may be coming to me within that first week or two if we're lucky. I know back in when I would dry needle that syndesmotic joint or where the interosseous membrane is. So I was taking a long needle, probably a 60 or maybe a 0.75 length needle, which is about 2.5, 3 inches long, 3.5 inches long. So you get there and I would stim it and just kind of get, trying to restore everything, get some biochemical mediators in there, kind of flush out some swelling and increase some blood flow, decrease some pain and swelling that way. That was one thing I did. But other than that, we're basically just kind of focusing on the impairments. This is an impairment driven, I guess, pathology where you want to bring them on slowly, with non-weight bearing, some neuromuscular control, and then progress them into weight bearing, and then obviously into the return to sport type things. Because this is usually a contact injury, I find there to be less impairments proximally. The last episode we talked a lot about regional interdependence and hip strengthening and looking at the core and the obliques and pelvic and all that good stuff, or pelvis. But in this one, since it's a contact injury, typically those athletes are strong and they're trying to resist falling and being tackled, and it led to that ankle kind of being torqued and leveraged because of that. Now, some of the things you probably want to consider are what I guess weaknesses or imbalances, quote unquote imbalances, have occurred because they've been in a boot for 2, 4, 6 weeks or however long they're in.
Yeah, or some of these like imbalances, come to light, I guess, per se, afterwards. And let's say if there was any imbalances, whether it may be hip weakness or, a dynamic, pes planus or anything like that, that could be exacerbating the pain because of those imbalances. A lot of things come to the light, after the injuries and those sort of things. So it'd be good to address those so it's not their poor mechanics elsewhere may, cause more forces to kind of go through that syndesmotic tissue and not allowing it to heal because it's constantly getting poked at more than it needs to. And then overall just addressing those impairments. Unless it's sometimes like a landing injury and they kind of like, they're like landing on someone's foot or something like that, and it kind of got forced in that excessive dorsiflexion eversion.
Yeah.
That's when maybe you can have, poor mechanics or something more proximally. But yeah, as you're alluding to, is like, again, this is more of a trauma based sort of thing versus a, no one gets a chronic overuse high ankle sprain or something of that nature. It's usually, happens as a result of the sport. So yeah, I mean, after those cam boots and those sort of things, as we kind of talked about last time, I felt, you take anyone who's even healthy and put them in those boots long enough, they're going to develop impairments, stiffnesses, and those need to be addressed, or their mechanics won't ever be the same, at least in my opinion. But that's is the dry needling painful for that process? I haven't done it. I haven't dry needled.
I can't wait for you to take that course. Not like you'll be able to use it, but I know you're in your fellowship and you'll have the ability to learn dry needling there. Yeah, I had different, I guess feedback from patients. Really, part of it depends on the patient's tolerance. Achiness was the biggest thing, like a dull, deep achiness, especially initially. Once you kind of got it going, because I had it hooked up to the stim, so I wasn't like trigger pointing them.
Okay.
Once they kind of get used to it, it feels good and kind of helps pump some things out. And just kind of, I'm using it of the mindset. And if you read a Shah's article in 2015, not 2015, 2005, he's really talking about the biochemical mediators, macrophages, blood supply, circulation, pH level, all those things that improve with the insertion of a needle. So I would approach it from that. Like, I'm just trying to facilitate healing. I'm trying to, obviously that interosseous membrane was ripped apart or torn apart, as well as the ATFL and the PTFL. That area has been traumatized. I'm trying to bring some blood flow and healing factors into that area to help expedite healing. Doesn't necessarily speed it up? Maybe. I didn't run a study on it, but it didn't hurt with it. And if anything, it would help with pain. And then, like we talked about last podcast on ankle sprains, I'm still trying to address any impairments or foot mobility issues or even strength issues within being able to maintain an arch, or maybe working on that midfoot or navicular mobility, assessing that cuboid. Because this is a trauma impact or trauma injury, and I believe you mentioned it before, really differentiate diagnosing between a fracture, whether it's an Ottawa ankle roll, or even something higher, like an actual break in the mid shaft of the fibula, or tibia, which would take a lot of force, but it's happened. That's where you want to really make sure, if you are in the front line, if you're a PT who has their SCS and works a lot of on-field coverage, that's something you want to look at as well.
Yeah, and as you mentioned, when you did these and did in those things, especially in the acute, high ankle sprain, a lot of them are non-weight bearing. So that's a time to be able to do those sort of things, to really just, decrease pain, decrease sensitivity, modulate the tissues and everything like that. No better time to do that sort of stuff when you're limited about what you can do exercise wise. So I always say that sort of stuff with, post-up shoulders or anything like that, where they don't have an active phase or anything like that. Do all your manual therapies, set yourself up for success, invest now while the patient can, only do a couple exercises on their own, or if they're like mindless exercises, they can do on their at home, and really invest on setting them up where they don't have a lot of pain right from the get-go. So I think that's great that you did that. So yeah, one day we'll get dry needling back. So
Sure.
But yeah, I guess progressing into exercises or anything like that. Is there anything specifically you try and do for high ankle sprains in comparison to your standard ankle sprains, or is it just purely impairment-based approach, tree as you go sort of
Yeah,
thing?
I wouldn't say that there's a go-to exercise or anything that I focus on. I'm looking at the impairments. Obviously, want to work on proprioception, leg strength in general. Confidence is probably the biggest thing. Making sure that patient is comfortable landing, decelerating, and then exploding out of that position. I'd say that's the biggest thing with these athletes. They're maybe more mentally concerned. Is their ankle or leg strong enough, or can it tolerate something like that? I mean, at that point, they're probably better off with a break. I mean, an ankle break, they're probably
Mm.
back in 4 or 6 weeks or something like that if they're young enough. So I don't on my side, I don't say there's like definitely one exercise that you need to do. I think it's a lot of the stuff we talked about before. Addressing your impairments and performing your single leg stuff, performing your hop test to make sure there's some symmetry there, performing your lunges and your squats and your RDLs and your single leg RDLs and things like that on my side. But I also just try and keep it simple and not complex and don't overthink it. It's sometimes my rehabilitation programs can be boring. You're doing the same thing and you're coming and we're just going to progress you each time, whether it's another set, another rep, a different variable,
Mm.
whether it's a kettlebell, a barbell, a dumbbell. I'm challenging your system that way. What about you, Jer?
Yeah, I agree with you. I would say, I mean, anecdotally, again, I haven't seen a ton of these. Maybe they've, just looking at like proprioception or ability to balance with their eyes closed sort of things, that they overall may struggle more than your classic lateral ankle sprain, more because it's higher trauma, higher shock to the area, more swelling, which is going to decrease, muscle activation if it's enough, and this probably, more prolonged non-weight bearing phase. So I may see maybe a little bit more of that. So I may implement more balancing stuff, but probably, again, it's what I see, I'm going to give it to them. And then overall, try and get them when they're appropriate, get into some higher level strength and conditioning to kind of fortify those, the interosseous membrane and those sort of things, because it is between the tibia and the fibula, a weight bearing joint. So that's pretty, just to kind of make sure it's not happening again. Luckily, I haven't seen. I know obviously, as we talked about in the NFL, I'm pretty sure Gronk struggled with his high ankle sprain.
Yeah, I believe he got surgery. I mean, that
I
had to
think
be
he
like
did.
5, 10 years ago, 7 years ago. But yeah, he ended.
Um, yeah, and I think he
That's been
was
another
rushed
night.
back pretty quick the
Yeah.
first time. So luckily, I haven't really seen too many reoccurrences. So that's always a good sign. I feel like last season there was a bunch. Who had a high ankle sprain last year? And he can't. Oh, Saquon. Saquon had a high ankle sprain, and he came back remarkably quicker. It's one of these
Okay, can you
classic
come in
things.
like 2 or 3 weeks?
3 or 4 weeks. But what was his, as someone who drafted him? In
Yeah, I drafted and traded him, so I'm a little bitter
oh,
about
you
it.
lucky
Plus,
bastard.
I'm a Cowboy fan in Giant Land over here, and that kind of
Mm.
came back and bit me. I think I traded him for Zeke though, so I was kind of happy.
Oh, so
But he
there
still
you
had a
go.
he still had a monster year though, Saquon.
It wasn't that great. Like for his in most leagues, he was drafted first overall. I was first overall. I was like,
Yeah,
all right, I'll
yeah,
draft him. He's young, but his performance definitely took a drop right afterwards. He came back, and it wasn't until maybe like the last week or two where he really started to heat up. I can pull up those stats, but yeah, he came back remarkably quick, and I'm sure he's going to be a reference for years to come, like Adrian Pearson has been referenced for the ACL. But he definitely wasn't the same person when he came back.
well,
Um,
one, he's also like 20 something. Two, I pulled up the
uh,
stats real quick because he had a pretty good year last year.
oh,
Last year he rushed for over 1,000 yards.
yeah.
And in 2018, he rushed for 1,300 yards. So he only missed it by 300 yards, and he missed like 4 games.
What was his yards per game after that, those first couple, or after he came back?
Like in-depth metrics here. I don't have that.
I'm just saying. I remember I was a little disappointed in him last. Not that I'm disappointed because he got hurt or anything like that. But whoops.
Maybe for another podcast we'll break that down.
Yeah, but I felt like he just wasn't running as well as he was. But obviously, he's coming back from a pretty significant injury and remarkable.
Their team also sucked. They stacked the box
against him.
Yeah.
But yeah.
Next
Have
year,
you seen the videos of him?
Which is
yeah.
Yeah, the quads are the size of my torso.
That's amazing. Like somebody once messaged me, they're like, I want quads like that. What do I gotta do? Like, yeah, you need that's God's gift to the world.
In your case, you might need some extra help.
Yeah, just do legs for a month and a half, 2, 3, or 2 years. But yeah, back on track there. Yeah, I think we covered a lot of things. I don't know if there's anything else you feel that we should recommend to the viewers out there, Brandon, when it comes to syndesmotic ankle sprains.
No, I'm actually looking this up here. Sorry.
Oh, looking what up?
His stats here. Yeah, so he had some rough games there. Because I remember they had a bye.
Mm-hmm. Then that helped him out because he extended.
That kind of helped him come back. But then he only had like 72 yards, then 64, 28, 1 yard.
Yep.
And he had like 66, 112, 89, 189, and 92. So those last 3 games he came out stronger. So you're right.
Yeah,
you're right.
So he came back early, and it took him about another month and a half to really get it back going. So,
so that was in 13 games. He had
it's still a good season, but
13 games. Anyway, we digress. That covers it for today. I think we touched on all the points. So, but if anyone has any questions, please feel free to message us or DM us or reach out to us in any way, shape, or form. I will let Jeremy handle that because he normally does and is much better at it than I am.
Yeah, feel free to reach out to us at Nips and Sips. We're on Facebook and Instagram. I'm at The Decent Doctor and at Trifecta Therapeutics. And Brandon's at Pursue PT Now and at Think Like a Fellow. Thanks for listening in, everyone. And, cheers.
Sounds good, guys. Cheers.